Hello, Journal Club 101, Mehrat here. I thought instead of going mad in the current viral situation, go madder and record my voice, plus the screen for you. Let's see for how long I can keep you hooked up into this recording. I had to go through vigorous tech training to make this happen, so you better stay interested. We're going to look at an interesting paper called The Diagnosis of Pulmonary Embolism with D-dimer Adjusted to Clinical Probability. For those of you who are going to be like, oh, we know that, this is not years, and this is not age-adjusted D-dimer. This is called PEG-ED. It was published in New England Journal of Medicine only end of last year, so it's very recent. What is it about? Well, we said it. It's a diagnosis of pulmonary embolism with D-dimer adjusted to clinical probability. Basically, can a higher D-dimer threshold be used to safely exclude pulmonary embolism? Yeah, so let's see. Let's talk about background. So they came up with this, these Canadians. They came up with this, that's going to be a great idea. So why? Because, well, in 2014, the JUST-P study showed we can safely use age-adjusted D-dimer to exclude PE. This is now what we use at Whiston for both DVT and PE. Basically, as a rule of thumb, if you're up to 50 years of age, the D-dimer cutoff for you would be 500 nanogram per milliliter. If you're 60, it's 600 and above. The years study was saying the protocol adjusted for pretest probability and a D-dimer of 1,000 was safe. It was mouthful, it's complicated, the subject to bias from my point of view. And I don't think it safely got anywhere because, well, you can talk about this later, because one of the criteria they had was, many of the criteria they had were quite subjective. But we're not talking about years here. They came up with this idea because the 2019 European Cardiology Society guideline says that the D-dimer now, as a test, should only be used as either age-adjusted cutoff or adopted to clinical probability, as years try to do and PEG-ED is going to do. Should be considered as an alternative to the fixed cutoff level. This is a level 2A evidence, which means that it should be considered. Alright, more on background. Basically, we need to try and reduce the number of imaging we do. Why? Simple. Because of the disadvantage of radiation exposure, contrast, high cost, and the time-consuming investigation it is, and obviously give less anticoagulant to people. Alright, so the question is, can a D-dimer use twice the cutoff of 500, yes, 1,000 is the number, be used to safely exclude PE? The design of the study was prospective, multi-center, a cohort study, all sounds amazing. Intention to treat analysis they used. The intention to treat analysis is a good thing, which basically means if you get enrolled into one arm, you get analyzed there in the end. If you get assigned to a low probability, no matter what intervention you receive, or even if you drop out, you still get analyzed based on your initial assignment. It is good because it actually mirrors your actual practice. For the geeks, you can see the power and sample conclusion for yourself, where the sample size needed was 2,000. And they used the estimate that the patients diagnosed with VTE at the 90-day follow-up be about 0.8% would be okay. And so if they use the rule out criteria of the PEG-ED algorithm. Okay. More on design. The eligible patients were assessed for PE risk using the 7-item Wells clinical prediction rule. That's what we use to categorize patients' clinical pretest probability as low, moderate, or high. Remember this, they're using the 3-tier system, slightly different. But anyway, let's carry on. The D-dimer threshold of 1,000 was being used in the study for people with low probability, that is the Wellness score up to 4, and you've got a moderate probability, which is a 4.5 to 6, your threshold was set at 500. Okay. More on design was the further investigation determined by the PEGI-D algorithm. So if you were low, that's 0 to 4, with a D-dimer for less of 1,000, or if you were moderate, that's the Wellness score of 4.5 to 6 with a D-dimer for less than 500, you would just go home. Obviously with safety net advice. The outcome of the study, which we're going to talk about them later, were assessed at 90 days after initial diagnostic testing by telephone or in the clinic. As we said, the setting was it's in Canada between December 2015 to May 2018. That's a good amount of years. Population: outpatients with symptoms or signs suggestive of pulmonary embolism, not inpatient, just outpatient, which is pretty much mirroring our practice for low risk and ambulatory people. Exclusion criteria: it's a big list. You can read it. Age of below the 18, if they receive some sort of anticoag therapy for 24 hours. That's what we do for all of our ambulatory patients. Anyway, major surgery in the last 21 days. D-dimer level known before the assessment was being done. So, isn't it pretty much most of our patients? Chest imaging performed against the protocol, then they would get excluded. If they needed CT for another reason, or they were already on anticoag therapy, which is again a good thing because D-dimer using is completely useless. Life expectancy of less than 3 months, they made life easier for themselves, or pregnant or people who are not accessible. Alright. People not accessible. I think the Canadians need to start thinking about using pre-hospital or some Zoom meetings. Clearly the Commonwealth countries are not as high-tech as us, are they? Alright. The population, 2017 patients included in the end. That was more than 3,000 initially signed, but then excluded because of the exclusion criteria that we set, with a mean age of 52, and about 66.2% of the population were female. 1,752, that's 86.9%, were low risk. 280 were moderate risk, that's 4.5 to 6 on Wellness score, and only 47 patients at 2.3% were high risk. The outcomes, the primary outcome which we were interested in was the incidence of any sort of VTE, either PE or DVT, during 90-day follow-up period among patients with low or moderate criteria, and a negative D-dimer testing who did not receive anticoag therapy. The secondary, well, in the predefined subgroups, the bleeding events, and if any deaths happened, and the actual number of the scans that they saved and the time, potentially. Alright. The total number of the people who were diagnosed with pulmonary embolism initially was at 7.4%. Pretty standard, I think. Numbers kind of are the same for us as well in the UK. No patients, this is important, no patients with low or moderate pretest probability with a D-dimer level below the predefined threshold, that is 1,000 if you're low and a 500 if you're moderate, had evidence of symptomatic, objectively verified venous thromboembolism at 90-day follow-up. That is great news. Out of 1,285 patients who had low probability, 350 patients had a D-dimer level of a 500 to 999. These are the 350 people that would have had a scan if we applied the current practice to them. And none of these patients actually had follow-up, had a VT on follow-up. So by their measures, the chest imaging was reduced from almost 52% to 34.3%. That's a relative reduction of about 30% compared to usual practice. Okay. There were 7 major bleeding episodes, 23 minor bleeding episodes, and 34 deaths during follow-up, the 90-day follow-up. They did not attribute any of the cause of death to a VTE at all. There were other causes of death, so you can just look at the tables yourselves. They concluded, ruling out PE in patients with a low probability who have a D-dimer level of less than 1,000 nanogram per milliliter is a low-risk strategy. This strategy is also appropriate for excluding PE in patients with a moderate probability who have a D-dimer level of less than 500. But, really? Okay, we talk about it. Okay, strength of the study. Let's just say, actually, if you say stuff that I'm going to say now, you'll pass your critical exam, and when it finally happens for the registrars in the next decade. So, the main important strength of the study from my point of view is it tries to answer a question very, very important to our day-to-day bane in life. We all have the fabulous relationship with the D-dimer test, especially the 99% of them that we did not want in the first place. Other things, strength is a multi-center study, large enough, with power calculation, performed for the geekies. They use intention to treat analysis, the thing that we talked about, and very few people actually they lost to follow-up, less than 1% accurately. And following people up after 90 days is reasonable and good, and they actually did it very well. Okay, let's talk about the weaknesses. Well, firstly, it's not randomized, is it? No control group. Did actually patient receive better care or not? We cannot compare at all because we don't have the two groups, one receiving the PEG-AD algorithm and the other group as our standard management. Although we do not use a 3-tier system in the UK, even if I wanted to use their system, the number of patients that actually allocated to moderate is actually very little, only being at 218 patients, and applying the rules of PEG-AD meant only 40 patients did not receive a scan. That's only 40 scan reduction. Overall, only 13 patients of their population were actually in moderate or high risk. That's very, very low. I think all this raises the possibility of was there any convenient sampling there? Convenient sampling, as the name suggests, is just a type of non-probability sampling that involves the sample being drawn from the part of the population that is close to hand. There are subjective methods involved to decide which elements should be included in the sample, meaning did they try subjectively to just allocate more people in the low probability group? Were they trying to say that PEG-AD works better for the low probability group? Don't know. That and the lack of the randomization just raises the probability of seeing a big selection bias in their study. And talking about the exclusion criteria, have they used the best exclusion criteria? We mentioned that they're using the life expectancy, less than 3 months, as one of the exclusion criteria. And is that just make life easier for themselves if a patient is going to die in less than 3 months and they didn't want to have a higher rate of loss to follow up? And the other thing in the exclusion criteria for us applying in the day-to-day practice would be the fact that we actually give patients a dose of anticoag and bring them back for a scan the next day. Does that change the finding of a scan? But will I apply this to my day-to-day practice? Well, we have got a two-tier system, so a bit different. We cannot actually think about moderate or high, and nice clearly is tightening our hands. And even if I didn't want to follow the NICE guidelines, the number of people assigned to moderate or high risk actually very little to be able to judge. What I do is that if they're under 50, I love to use the PERC criteria. And if the PERC negative and it looks like it clinically, I'm not going to even go to use Wells score. In low risk people, after they pass the PERC criteria, which is for us in the UK less than 4, I would definitely consider using a higher D-dimer level. I know we use age adjusted, but sometimes, come on, we can say, maybe we just go above the age adjusted sometimes. Now we have got better evidence. But certainly, decision is a case by case. I would consider adding bedside echo, and after all, if in doubt, just scan. Thanks everyone. We can follow this up with a proper chat.